So I'm excited to be here again. I currently work at Florida ENT and Allergy, and I, dropped the bomb that I'm going to be at USF as well. So I'm excited by that. Okay. All right, let's get rolling. So I have no disclosures for this presentation. This is a freebie, right? But the reason why I came today is because I am very passionate about patients understanding what it is we do. Just like I presented for Megan, people don't realize what we do. So I want you to understand what specifically our role is as a speech-language pathologist. How do we diagnose you when you come into our room? And how do we treat you? What are some of our approaches? So let's start with just knowing that we are an integral part of the voice care team. So when Charlie, no, it wasn't Charlie, I forget the person's name, I'm sorry, who came up and was asking questions and said, did you see multiple people, right? Yes, okay. Did you see multiple professionals for your voice disorder? And a lot of people raised their hands, okay? So you may have seen a lot of healthcare professionals before you got to your diagnosis, but I can tell you it's not a bad thing that you have multiple healthcare professionals on your side. It's a voice care team. We are an integral team at building a platform for you, building what we think is good for you. So here you see there are many different professionals, from a laryngologist. You might see your PCP. You might see a counselor, a dietitian, a physical therapist. But today we're talking about speech-language pathology, which is bolded there. Okay. So the foundation of speech-language pathologists, who in the world are we? Where do we come from? How did our profession get started? You're going to learn some great things that you're going to be able to go and share with other folks today. So your physician has referred you. You're like, who in the world are they? Let's look at some history of how we came about. And in doing this research, I was so excited. I loved looking this up. So the first idea of speech therapy was actually this thing of speech correction. And it began by addressing stuttering. Okay? They used a technique called prolonged speech treatment. And the person who did that's name was Elijah Corlett. He was a schoolmaster at Cambridge Grammar School in Cambridge, Massachusetts. This was the first patient he worked on, a Mr. Cotton Mather. So not only did Mr. Mather use this technique to help with his stuttering, also Alexander Graham Bell and his father were stutterers, and they used this specific technique. We kept evolving. There's correctionists, they're working with the stuttering, and now we put things to print. So Edgar Warner had the first journal called The Voice. So there was stuttering, now The Voice. At 1879 through 1882, Edgar Warner was a director of a school for stutterers in Albany, New York. And so publishing this first journal on communication disorders was really something big in our field. So now let's just look at some historical perspective, some more information. There were special interest groups like the National Association of Academy of Academic Teachers of Public Speaking. This was formulated and was in existence from 1914 until 1922 with President James O'Neill. Started with just 17 members. I don't know if we've grown. We've grown, but we're still a small organization. First convention was in 1915, and then we moved into National Society for the Study and Correction of Speech Disorders, and that was around 1918 until 1939. The founder and president is this person pictured here below, and that was Walter Babcock Swift. This is what I loved, and that was, and Yasmin, you'll like this too, and that this person was a laryngologist and a neurologist. And I was like, okay, so voice was there in the early years. People just didn't know it. So here you have a list of the historical names of everything that we were called until we got to 1978 of who we are today, the American Speech-Language Hearing Association. Whoop, whoop, we're so excited. All right, so now we have a name. We have an organization. We're a body of professionals. Now it's time to set practice standards and requirements. So when you walk into the office of a speech-language pathologist, That's what the SLP means. It's not speech-language therapist. It's not speech therapist. Our name is speech-language pathologist. What are those C's? What means we hold a certificate of clinical competence, which we earned through the American Speech and Hearing Association, as well as our degrees. What are our degrees? We either have a master's in art, a master's in science, a doctor of philosophy, or a doctorate in speech-language pathology. We have taken a national test and had to achieve a passing score. And following that, we have a 9-month clinical fellowship where we are loosely supervised, but still we're not being holding hands with anyone. Every state that you go to, you have a right to ask, what is your license? Do you have a picture of your license? Because we are licensed in every state. We also are mandated to have so many continuing education units per cycle of renewing our licensure and renewing our certificates. We now have speech-language pathology assistants. Just like PTs have PTAs, OTs have assistants, we have assistants. They have an earned bachelor's degree, and as well, they are either certified or they're registered. So don't be surprised if you go into a clinic and you might be seen by speech-language pathology assistants. Now you know that what credentials they have. Now, in my field and when I see patients every day, education is always key for me. When people leave, they feel like they have just went to school. And that's okay, because that's what I want you to know. I want you to learn about how the voice works. And I've already covered this, so I'm not going to go through it too much, but just want to emphasize again on the 3 areas of voice production, from your airway, moving up into the larynx, the oral cavity, and your resonator. The little pictorial here on the right-hand side just really shows you that when the airstream begins to go up through the vocal folds, your vocal folds actually start in a closed position, not in an open position, okay? That's why, like with adductor spasmodic dysphonia, it's so difficult because we already start closed, so you're closed and you're staying closed, okay? Because if you notice there in number 2, 3, 4, and 5, that is where the vocal folds should start to open. But unfortunately with SD adductor type, you're not getting that cycle, okay? So we talked a little bit before about the size of the vocal folds. I wanted to dive just a little bit deeper into that. So this is the evolution of size. You're going to start like about a dime size. The V there is just to represent a symbol for the vocal folds. And so a female will be between the range of 12.5 to 17.5, merging from a dime to a nickel. And then on for males, 17.5 to 25 millimeters up to the size of a quarter. So at birth, vocal folds measure 6 to 8 millimeters, but the adult length is achieved by the time you're an adolescent. All right, so the fun time. Let's jump into diagnostics. So our testing is a combination. It's a combination of looking, we listen, and we also are always involving our patients. We're also gathering objective data because we're analyzing your voice. I analyze voice from the moment I pick you up in the waiting area. I analyze voices everywhere. One time I've been numerous places, but one time my physician, my laryngologist, Dr. Vincent, says to me, he comes to my office and he goes, "You did not tell someone to come see me when you were getting your hair done." I said, "Yep, sure did." I'm sitting there and I'm like, I just can't take this anymore. And so, and my adult children, which Ron and Jim, they've watched my kids grow up and now they're adults. And, but when they were teenagers, we would be out and they would say, "Don't say anything. Don't say anything. I know you hear that voice. Don't say anything." I'm like, "I'm going in. I got a business card. I'm going in," right? So now they're trained. They can even hear voices and they know a voice disorder. So it's quite funny. But patient-reported outcomes are a part of behavioral and qualitative analysis of voice and resonance. That's a mouthful, right? But you are important. What you think about your voice, how you feel about your voice, how it interacts with your everyday living is important to us because what we do is always patient-centered. This is a staple in most voice centers, and this is called the Voice Handicap Index, where you're rating specific parameters based on a score of 0, which is this never happens, to 4, it always happens. So an example would be, and these were some of the things you guys talked about before. I feel left out of the conversations because of my voice, right? My voice problem upsets me. People ask me, what's wrong with your voice? Or people have difficulty understanding me in a noisy room. Well, I think some of these are true for everyone sitting here, right? So another part of how we analyze your voice, this is the listening part. Again, when you walk in, look at all of these descriptors, okay? Because we want to actually add that quality, and to what degree. So if I rated someone's voice and I said, okay, this voice sounds strained, and I'm going to say it sounds strained from a degree of mild, moderate, or severe, because that's going to help us as you continue to progress on your journey of rehab, whether that's Botox or speech therapy, okay? You probably can see yourself up here, tremors. Are you hoarse? The glottal fry, which we call the Kardashian syndrome, where you're talking down like that, right? Funny story. My sister and I we lived in a town called Hill Station, and this is in Pennsylvania. And we moved to a different city called Cannonsburg. We would lay in our bunk beds, and we'd say, we're going to play Hill Station. And we would go, hey, how are you? And we would talk in glottal fry. And then I become a speech pathologist, and I said, my Lord, I was just having a lot of not doing good things with my voice as a youngster. So... okay, another behavioral qualitative is we are going to look at those areas of resonance. So I want to know, how do your lips work? That's labial, lingual, your tongue, and your palate. Then I'm also going to look at your dentition. You didn't think that's important, but it is. Take those teeth out and try to say some of those interdental sounds. Not going to happen. And then, are you having any tension in your jaw, neck, shoulders, face, or lips? And what's your breath support? Are you breathing here? Are you breathing here? Are you breathing from where we need you to breathe, the abdominal area? Because we want that dome-shaped, dome-shaped support from your muscles, right? We want things working well. We want that diaphragm doing what it should do. Or are you speaking on residual air, which means you just talk, and then when there's no air, you're still talking. Okay, so you got to renew your breath to give yourself the power source needed. We do some other things using instrumentation. So the S to Z ratio and maximum phonation, simple stopwatch, okay, but you got to know how to use it. Got to teach my students that all the time. And the reason why we're doing that is maximum phonation will let us know, do you actually have the air supply needed? That's the is kind of hard, though, when it's a diagnosis that doesn't permit the vocal cords to do what they need to do. So I find out a lot of information when I simply do the S, because it involves no vibration of the vocal folds, right? You're just letting the air out. So that gives us good information. Now here, these other two pictures are showing you information from having a patient read. So they might read that good old rainbow passage. I have another passage, when the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. You know how long I've been working, because I know that almost verbatim. But it gives us good information on what's the intensity of your voice. Are your vocal folds working in sync? Is there more energy being put forward? Okay, it tells us what your pitch level is so that we can compare your pitch with those of your age range and gender. All right, so who's seen any of these instruments? Who's seen them real up close? Yeah, right? You've seen them up close. But speech pathologists use videostroboscopy. Your laryngologists use videostroboscopy, but they're also using it as just looking at your vocal folds to see if there's any anatomical changes, right? So Imaging using that strobe light is so important for me as a speech pathologist because it's telling me how the vocal folds are actually moving. And what I love to do as well with videostroboscopy is dynamic assessment because that allows me to see if what I would do in an actual therapeutic setting would help you. Okay? So the biggest thing about the strobe light is this bottom bullet point, that this process resembles a motion picture or a cartoon. Because when I educate my patients on why, because they'll say, I saw the laryngologist or I saw another doctor. They already put that thing up my nose. Why are you doing that again? And I say to them, think about this. Watch a car going down the street. Now you know your mind is not playing tricks on you, right? That car is moving forward, but it looks like the wheels are what? Moving backwards. Because our human eye, our retina, cannot process that speed. That is how fast your vocal folds move. You can't see that just with a regular light source. So you're coming to a speech pathologist to get the light source. Come see the light, right? Okay. All right, so I'm going to give you this example. This is a stroboscopy that started without the strobe light on, by accident, I will say, because our equipment is cheap. No, I'm just joking. And then the strobe light, then it did come on. So let's give this a look here. It'll play. If I can get it to play. There we go. So see, it looks like you're just looking at something that's a blur. Nothing's moving on those vocal folds. Now we're going to get the strobe light on, and you can hear it. Now they start like they have some movement. And then the person gets to the end of their breath stream, and they're squeezing more, and it almost looks like that movement is gone, right? So this is a case of someone having muscle tension dysphonia. And I have another one that just gives you the example. Let me move on forward. Okay. And you can see the movement from the beginning, the open and closing. But that patient also has compression, so they also have muscle tension. So what does videostroboscopy give us? What do we gain from it? Well, recordings of the vocal fold vibration are analyzed with this type of test and shared with us so we can guide our treatment, as I said earlier. And we can also use it to monitor disease processes, and we love to look at this for pre- and post-operative outcomes. And when I was looking over this, trying to decide, which one of these points would anybody here in this room understand, as a novelist, I think that you would understand number 10. That's the glottic closure, and that is when your vocal folds are at maximum point of closure, what does it look like? Is there an opening, or are they fully closed? Are you able to keep air underneath so that you can pulse it out when you're speaking? And number 4, I think you can appreciate supraglottic activity, and that means, is there compression, as you saw in those other 2 videos? There is compression or squeezing. Okay. I'm going to run through treatment. I'm trying to talk fast. Okay. All right. I want to preface when we talk about treatment that we are planning our treatment based on patient-centered functional goals. This is something that is developed and advised by the World Health Organization, so that our treatment goals, we're having a discussion with you. It's a partnership between your speech-language pathologist, the patient, and the family, because we want your goals to be functional. So I can give you one example. I had a lady that came in with vocal fold atrophy, was told, go see speech therapy. I don't know if that's going to really work for you or not. But she said, you know what? I want to preside over my granddaughter's wedding in California, and that's happening in like 30 days. So that's what our goal was. That was our game plan. So you have to make sure, if you feel like you're just sitting down and your speech pathologist is saying, okay, do this, do that, do this, and you're like, how is that meaningful for me? What is that going to help me gain? Is that going to help me read a story to my grandchildren? Is it going to help me order something at a restaurant? You have to ask those questions because you are an important and vital part of your therapy. So I had a few exercises. I'm just going to kind of go through these quickly. I did bring things with me. If you want to ever do this with me today, you can find me. So cup, bubble, or lax vox. This is what we classify in a system of what's called semi-occluded vocal tract exercises. These have been around for decades. There's different variations, different tools, different things that you're trying to achieve. Lax vox, which is the same thing, is a voice therapy technique used to improve your vocal function and to reduce tension in the vocal folds. So basically what you're doing is you'll use a straw. You want to pace yourself. You're putting the straw in water and you're blowing bubbles, okay? But if you decide to do this at home on your own, beware, okay? You can't have a lot of water. I just saw a telehealth patient who we showed her how to do this, and then the next week she said, my goodness, I did those cup bubbles and I was just so tired and it didn't feel good to me. And I'm looking at the glass she has and it's like almost as full as my water bottle with her straw down in the bottom. I'm like, okay. Think about when you jump into water. You have less control and you have more resistance the deeper you are in a pool or in the ocean, right? You come up to the surface, you feel better. So you want to have just about maybe an inch or two of water. Stay on the surface, okay? Another exercise are these tongue trills. Anybody asked to do these in therapy before, or lip trills? Yes. I did, 30 of them on my way in, so that my voice would be okay for talking this morning because I had 2 presentations. But what I love is that this reduces tension in your tongue, your lips, your oral cavity. It will help improve your pitch range. Very simple to do. You can do them anywhere, right? Walking, driving, in the shower, when you sit up, before you speak. You know, use them as a warm-up and a cool down. And let's see here. The final one I want to talk to you about is vocal function exercises. I love vocal function exercises for my tremor patients. I love them for people who have paralysis, paresis, and once muscle tension patients, dysphonia patients gain more control over their voice, I like these for them too. One of our few holistic approaches. What does that mean to you? Holistic means the whole system, from respiration, phonation, to resonance. And that little photo over here is just an app that I'll tell all my patients to get, which is called Pitch Perfect. Because in this program of the 4 different steps, you are matching to tones, okay? So in summary, we want to know, as speech-language pathologists, about each individual system. We want to know how those systems will work because that's going to drive us and how we are ultimately going to treat you. So I want to thank you for your time and your attention today.